Your colleague Sir Patrick Vallance told the committee that SAGE always gives a range of options to government ministers to take a decision. Could you just quickly confirm that, please?
It entirely depends on what the question is, actually. Sometimes the view will be, well, there's just one thing which makes sense here, but there may often be other options available, or very often it's much more to do with how you operationalise it. So the central principle may come from SAGE, this is the clear advice scientifically broadly, and then policy officials may say, well, within that, here are 3 or 4 different ways in which you ministers could choose to actually use this advice. And that's a much more common situation where ministers are given policy advice with options based on a broad set of scientific principles and guidelines.
So if I take just one specific example, the Prime Minister took the decision to allow mass gatherings to go ahead, such as Cheltenham and football matches. Was SAGE unanimous on guidance around mass gatherings, and were the predicted mortality rates without lockdown and without systematic testing provided to the government advisors?
Well, the decision as to whether to cancel mass gatherings clearly is finally a decision for ministers. The SAGE advice you can read in the minutes, and it's actually very, very clear, which was not that they were advising that these should be kept open, but neither was there clear advice that this is the thing you must do first, is close these down. There was quite a complicated debate around that, actually, which was around if you suddenly close things and people are kind of kicking around, are they suddenly, instead of going to a stadium where they're all in the outdoors, going to be in pubs and so on? I'm just saying that's an example of something where actually the sort of the science and the debate behind that is rather more nuanced than the kind of headline figure might be. And but I think that's just an example of one of many of these kind of choices.
Area where you did give very clear advice was on May the 11th. You advised people to wear masks where it's not possible to social distance indoors, and that there could be benefits, particularly on public transport and in shops. 2 months later, we had confusing messages from ministers before a decision was made. We'd heard earlier from the panel how important clear communication and consistent communication is during this pandemic. Do you think the government could have been clearer and quicker about the benefits of using masks in confined spaces?
Well, I think masks as an example is probably the clearest example, in fact, of something where the scientific advice in terms of the consensus view shifted during the period of the epidemic, not just in the UK, but WHO and many other countries as well. So the first point is the scientific advice. There are many areas where the scientific advice was absolutely consistent all the way through the epidemic. This is actually an area where the scientific advice shifted from a more cautious to a more positive stance. So that's the first general point. Second point is that the question is not around giving advice about whether masks should be used, where I think our advice is actually reasonably clear. But this goes back to your previous point. Then the question is, okay, so how do you in which environments is this going to be mandatory, which is an issue of the state, and in which environments is this going to be advisory? And that's really where ministers have to make policy choices. But our advice in terms of where you should use them is absolutely clear and consistent, and in my view, can be understood by everybody, which is any situation indoors where you're not going to be able to maintain social distancing, wearing masks with our current advice reduces the probability that if you have asymptomatic COVID-19, will pass it on, and therefore it is a good thing to do. But in those environments, we're not advising it outdoors, but in those environments where you cannot maintain social distancing, that is currently our advice.
Thank you, Professor Chris Whitty. I mean, that doesn't, I can understand the shift in scientific advice, but that doesn't explain the delay for 2 months between the scientific advice and the government's actions. And I don't expect you to be held accountable for that. The question I have now is around the UK has recorded more COVID-19 deaths among healthcare workers than any country in the world except for Russia, with over 500 deaths. Guidance from the government was downgraded on PPE on March the 13th. Was that on guidance from SAGE, and was everybody in agreement?
So I think that this should be clear that this is actually conflating 2 slightly different questions. There's a question around the categorization of the virus, and then there's a question around, and then around PPE, and then there's a question around healthcare workers. Start off with the healthcare workers, because that is by far the most important part of this. And as a healthcare worker myself, I absolutely, bitterly regret every single death in any healthcare workers from whatever cause. If you look at the statistics, and this is where the technical side of this comes in, how can we protect people from mortality and long-term effects of COVID, which some people sadly have even when they fortunately recover in terms of not dying. The critical thing, and the thing which would reduce cases in healthcare workers and everybody else, is to keep the rates of the virus down. And quite a high proportion of healthcare workers will have got their virus in the community, and that's from the high community transmission that the UK suffered. Within the hospital settings, in those settings where PPE was routinely used, the rates were much lower actually than often in ancillary and other areas where that was not the case. So PPE clearly has a very major role, and the actual grading of the PPE is probably much less important than the actual whether people used it at all, and we're using the actual the techniques that we are now currently using to reduce infection rates. But to be clear, healthcare workers have always, and in this epidemic have continued to, take risks when they're caring for people with highly infectious diseases with a significant mortality rate.
Okay, that doesn't explain precisely why it is that we have seen such high levels and numbers of healthcare worker deaths in comparison to other countries. And what was the guidance from SAGE on downgrading PPE on March the 13th?
So I mistakenly was preparing for a forward-looking committee rather than a backward one. This is
crucial. The reason why this is crucial is because if we are to live with COVID-19 for a long time, and we've heard from other panel experts about the need to be able to start services again within the NHS to clear the backlog, to make sure that we're not having problems with hidden cancers in the future, for example, the issue of PPE and making sure that we get this right is important for the future as well. So it's to whether we will see any changes in guidance on PPE, and also therefore making sure we've got the correct supplies.
Yeah, so on the forward-looking and on now, absolutely, I can answer that. I just remembering exactly what committee said what when is just something I hadn't prepared for, and therefore I don't have it in front of me. So in terms of the PPE now, I think that we are confident that the PPE advice that currently exists seems effective. It's in line with other countries and WHO norms, and the data actually shows that in those bits of hospitals where PPE is widely used, there's no clear evidence of any increased rate over background rate in the general community. The big risk to healthcare workers is from the fact there is background rate in the community, both directly and then the indirect effects through hospitals. Within hospitals, there is reasonable evidence, not great evidence, from genotyping that actually a lot of the transmission in hospitals was from care staff and health staff to one another, and then equally patients to one another, but less between patients and healthcare staff. So there's just as much risk in people being in a, let's say, being in their break room as there is actually being on the wards in these kind of situations. In terms of the actual supply of PPE, it is pretty clear we had very considerable problems on supply through a large period of the early part of this epidemic. And we're going to continue to have challenges on that, but much less, I think, than we had. And the problem fundamentally is every country in the world wanted this, and the supply was highly constrained. But at this point in time, and supply is absolutely not my area of speciality, so I'm only quoting the views of others, but at this point in time, their view is that our supply lines on PPE are now much more secure than they were a couple of months ago, much more secure. But if we have a major surge in the winter that is simultaneous with a major surge in the winter in many other countries, I think it would be foolish to say that the risk of this has gone completely away. So I am reasonably confident the advice currently is good advice, is properly followed. The practicalities of it are obviously something we need to keep absolutely on top of all the way through, particularly